Hello everybody, and welcome to this question and answer session. It's been organised through the Mental Health Innovation Network, and today's topic is on health economics. And because some people feel less than comfortable or glaze over the subject, the mention of this subject, we've entitled it Demystifying Mental Health Economics. And the idea is that people can pose questions that they are facing in this area, and we will use this opportunity to discuss some of those questions and share those thoughts with the global mental health community. So my name is Dan Chisholm, and I'm based at the World Health Organization in Geneva. I work in the Department of Mental Health and Substance Abuse, where I work in health economics and financing, as well as broader issues around mental health system development. We sent out some invitations for questions some days ago. We actually only received some questions very recently, so we've gone ahead and prepared some frequently asked questions, which we thought could form the basis for the third part of this. And then we have actually received some questions from people, as I said, just very recently, and so we can address those towards the end of this session. So let's move ahead. The next slide that we have is here. Here are some of these frequently asked questions that are posed, which I think covers a lot of the key issues around designing, thinking about economic analysis alongside doing research on global mental health. So the first one, which is always a good way to start, is the why question. So why is an economic perspective on global mental health relevant or useful? So put another way, why should I be even thinking about this or bothering about it? So we address that. Then we move to questions around the what, the when, and the who. So what are the key stages in doing an analysis? What are the things I should be trying to measure when doing an economic analysis? And then there's also a when question, when is the ideal point at which you should start thinking about undertaking these kind of studies, and at what point in the data collection sort of cycle do I need to be thinking about specific data needs for this type of analysis. And then a who question, which is who are the people who need to be involved in doing such an analysis at different stage again of design and evaluation. And then finally a how question about the key issue is, how do I know, for example, if my innovation could or should be deemed cost effective or affordable, and also how can I learn more in this topic. So we're going to go through some of those questions and then address some of the specific questions that came in from members of the network. So why? Why is this topic relevant? And the answer to that is the standard sort of response, really, that there's never really enough money to do everything that we like to do. And this is the problem of resource scarcity, which forms the basis of much economic analysis and of economic thinking. So if you didn't have enough to go around for everything you'd like to do, that means you inevitably have to make some kind of choices about which actions you pursue or how you decide to spend available resources. Of course, in that kind of context of resource scarcity, it makes sense economically to use those resources wisely or efficiently and not wastefully. There's a huge amount of waste that goes on in the health sector. A World Health report from 2010 for example, looked at this issue and estimated that anything between 20 or 30, even up to 40% in some parts of the world of all healthcare expenditures could be considered inefficiently spent or in some cases actually just wasted as a result of corruption or other inefficiencies. So that's really the main starting point for this, that you need to think carefully about, when thinking about global mental health innovations, do these represent a good use of available resources for health? So, closely related to that, why should I bother to assess the economic implications of my innovation? And the other way of looking at this would be that you could have a fantastic innovation which you present to your local decision maker, but it's quite likely that they will turn around and say, yeah, it's a superb innovation. And I've just got one question: how much is it going to cost to me to implement this? So if you don't have answers to that sort of question, that's going to place an important limit on the uptake of the innovation. So what I'm saying is that it's likely, increasingly so, in many countries that particularly where resources are very scarce, or resources are only stretched across many different programs and other competing disease priorities, you really need to make the case and demonstrate or come along with evidence that the innovation does indeed represent good value for money, or is indeed affordable in the local context in which the innovation is going to be scaled up and implemented. So that's sort of two important arguments for, if you like, justifying an economic perspective in global mental health innovation and research. Then moving to the what, and the first thing that obviously you need to think about is in terms of design. So the first thing I should do is think about the design of an economic study, and that will very much depend on the question that I'm interested in answering. It might be a very straightforward question that just looks at what it might cost to actually provide or implement an innovation in a particular target group, so that you can say whether the cost of my intervention is reasonably high or reasonably low or very cheap, whatever it might be. That's an important piece of information and evidence in itself. So let's say you're developing some psychological treatment or brief psychosocial interventions for mothers or for women. Let's say women affected by domestic violence. So you put in place some health, some additional health resource through health workers. They have sessions, there's some training, there's supervision, maybe there's home visits. So sort of totting all of those up and establishing what the actual cost of that implementation is going to be, should it be sort of rolled out. A second, a bit more involved kind of economic study design would be to take those costs and relate them to the primary outcome measures of your study. So, in the example that I just gave around evaluation of an intervention for addressing domestic violence for women, the outcome might be in terms of reduced stress or depression, other key outcome measures around functioning and so on. So you would relate the cost of your intervention to those health impacts or benefits. That would be a cost effectiveness type of study design. So those would be perhaps the two obvious types of question that you might address and the design that you would use to address them. If I break those down, so in terms of what I should be trying to measure when I talk about costs and outcomes, so I gave some examples a minute ago, but if you sort of categorize them, the three that I've listed here, the first is health and other welfare-related service costs. So that would be any intervention costs that I just, for example, mentioned around psychosocial treatment sessions. But it could also extend to medication, of course, laboratory or diagnostic tests, and any visits to primary care or to outpatient care, inpatient stays, and so on. So that's obviously an obvious set of healthcare-related costs that you would need to capture. Then there's another category which would be the time costs. So for a lot of people, actually getting to and accessing care is a time-consuming business. So it would be important to try and often to try and capture those time costs. And for certain particular conditions, let's say, for example, dementia, then informal caregiving is can be a very substantial cost as well. So the point being that if people weren't spending time accessing care or providing informal care, then they could have been doing other things with that time. So in that sense, there's a so-called opportunity cost associated with the time spent getting to receive care or provide informal care. A third category would be in the area of productivity costs. So this is when you're talking about people's ability to go back to work if they've been disabled from working as a result of their ill health. So that's another important economic kind of cost which you'd want to sort of identify at baseline, and then in terms of the outcome, you would, as it says below, be able to see the extent to which those losses have been reduced or averted as a result of intervention, and people being able to go back to work, go back to their other daily activities. Moving to those outcomes then, the main starting point in terms of thinking through outcomes would be health, obviously, so there might be very specific disease-related outcome measures around for depression or for psychosis or for epilepsy, for example. So different diseases would have appropriate sort of measures of reduced symptoms or severity. But we can think a bit more broadly that as well and think about functioning measures or disability measures, quality of life, and so on, which cut across a bit more. They're not disease specific, but for example, there is the WHO's disability assessment schedule, which can be used, across a number of different conditions, and that then provides you with the ability to compare across interventions across disease areas. And then I mentioned the social and economic outcomes as opposed to health outcomes. So as I said, this would be to do mainly with being able to go back to work, maybe improvements in income if you've got a long enough period over which to measure that, other livelihood measures, social participation and integration measures, and these kind of aspects, which can also be extremely important to try and capture. So that's a very quick overview of some of the main types of information that you'll be trying to capture in an economic study. Let's move on to another question, which is the when. So when should I start thinking about this? And the simple answer is not too late. Really needs to be thought about at the design stage, the evaluation design stage, not, as it says here, halfway through the study, which does tend to happen sometimes, but it's only halfway through, post initial design stage. So I think, oh, hold on, we better collect some information about costs, and we want to do an analysis of the cost effectiveness. But if you haven't started thinking about it at the beginning, you might not have considered all the information that is needed to be collected, and therefore you're stymiing yourself. In fact, it says here, and I think this is right, that really, it's important to actually think about this when applying for funds, because undertaking this kind of analysis is not cost-free. And funding bodies are generally very enthusiastic and keen to see the inclusion of economic evaluation in health services research of the type that we're talking about today. So getting some funds together for actually doing a value for money or cost effectiveness study is obviously a good way to go. So earlier than later, I think, is the summary message for when I should start thinking about this. And then in terms of the actual data collection, when should I be collecting the data? Well, there's a number of aspects. The main one is to make sure that alongside the other information that you're collecting in an intervention study, both at baseline and at the various follow-up points of a study, it's important to include information necessary to undertake an economic analysis. So in particular, that would mean this service utilization profile that people in your study are going to have. So we talked already just a moment ago about people's use of primary care services or hospital-based services, any use of medicines, lab tests and so on. So you need a questionnaire in there at the baseline stage of your study to capture that service utilization. Otherwise, we're not going to be able to identify what are the overall costs. So service utilization, and then when one does that, then you can then subsequently and separately attach a cost to that service utilization. So if you find out, for example, that on average people go to have 4 outpatient visits in a year of follow-up following this intervention study, then we can place a value of the price on each of those outpatient visits. And so that is a separate piece of data collection that I would need to build into my plans for the study, which can be done, as it says here, separately, independently. I just need it's a sort of one-off exercise to go off and calculate what does one outpatient visit cost in my local country or context. What are the medicines that are being used by my target population? What do they cost to use on a monthly basis, and so on. So we can then multiply the service utilization patterns by the costs or the prices of each item of service use. And there are a number of simple templates that are available for obtaining that data and also for collecting or recording these so-called unit costs. So those are 2 important building blocks for doing data collection and subsequent analysis. Let's move to the who question, because a lot of these analysis or analytical stages that I've just mentioned might seem that they are the preserve of some expert health economist or something, but actually no. I would suggest that really global mental health innovators and health services researchers are are very capable and really should be the people who really lead this kind of work. There might be the need for some health economic advice or assistance, but really just think of it as another dimension of clinical evaluation. And everyone trained in health services research is familiar with the key stages and aspects of that. So all we're doing is adding in an extra sort of questionnaire around full utilization, and there is some analysis, as I said just before, about collecting what is the cost of various things, putting those together into an analytical framework that you're familiar with, and proceeding. So, it's not rocket science, is the kind of take-home message. But as it says here, it might be useful to be able to consult with or get occasional input from someone locally who's done a similar kind of economic study, or someone else who can provide advice on this if you're uncertain or unfamiliar with this kind of work. So going through the various stages, we talked already about the design stage and how important that is. So for that, thinking about doing an economic study, clearly the PI and others involved in the application of the funds and designing the whole study need to be involved and aware of the requirements for doing an economic analysis. And then when the actual, assuming that funds are provided and it's all going to go ahead, I think it's good to have an appointed person on the research team who is like the focal point for this type of study. And that person, for example, might be asked to sort of pilot, test out some of the study instruments like the service utilization questionnaire, because that could vary depending on the local context or the particular condition or target group that you're working with. But also oversee, it doesn't mean to say you have to do, but oversee the collection of some of this unit cost data as well. Moving to the analysis stage, so this will just be another piece of data, another data set that is incorporated or integrated into the larger study data set. So you're going to need probably some kind of data manager or analyst anyway for help with cleaning the data and processing it. So this is another aspect of data cleaning and processing that would be needed. So then finally the reporting and communication stage. So as noting here, all team members, in all of the preceding stages of the study would be somehow involved or contribute to the writing up or the analysis or the interpretation of the results of the economic study, plus any advisors that you might have working on the project with you. So that gives you a sense of the kinds of persons who would need to be involved, ideally, in the study of this kind. And finally, let's just talk about some other sort of how questions, because this again sort of relates to the interpretation and the communication of results or findings. In particular, these concepts of affordability and cost effectiveness. What do they really mean? So it's difficult to kind of come up with a straight answer. But affordability is getting at the real cost of the intervention. So not around cost effectiveness, but just really is it financially feasible, your intervention? So I'm suggesting here that an intervention is likely to be considered affordable if it is cheap, obviously, or places a small burden on the budget. So it's whether your intervention, your innovation, can be accommodated within the existing or projected budgetary constraints of your local setting. Now, as I say, it's hard to come up with any hard and fast sort of recommendations, but anyway, here we go. I'm suggesting that for population-wide promotion or prevention strategies, perhaps something like, less than $1 per beneficiary might be deemed pretty affordable, pretty low cost. For treatment and care strategies, particularly in low and middle income countries, it can be run into many thousands in higher income countries, but an intervention that is going to cost less than $100 per year per treated case, for example, is probably going to be considered to be pretty affordable in most settings. Particularly, if as we move to next, it's leading to improvements in outcome. So let's move to that second one of the cost effectiveness issue, which again, perhaps the first thing to say is that cost effectiveness as a word is a relative concept. So it's always cost effective compared to something else, compared to what? And it could be compared to doing nothing, or it could be compared to usual care. But it could also be a comparison between, for example, a psychological treatment versus a pharmacological treatment. So you've got two different active interventions which you're doing a like comparison of. So always important to consider, well, what would count? When can you conclude that something is cost effective? So what I'm suggesting here is that obviously at a general level, going to consider cost effectiveness if it compares well in terms of cost effectiveness to other interventions, which might be either in the particular area that you're working in. So maybe you've got some new approach to screening or identifying cases of depression, and if it's found that your approach is a lot, leads to good outcomes and it doesn't cost so much, it's more cost effective than the prevailing mode, and that's going to be well received. But it might also be that the cost effect of your intervention, if you've got a suitable way of comparing results. So, for example, the cost per quality adjusted life year that has been gained as a result of your intervention, if that compares well to interventions in very different areas. So maybe comparing your depression study results to something for diabetes or maybe even HIV treatment. That would also be an important way of demonstrating that something is relatively cost effective. Now, there's also this, some countries, particularly high-income countries like the US, the UK, Australia, and a few others, they have kind of explicit thresholds for cost effectiveness. So, for example, in the US for many years, an intervention that produced 1 year of healthy life, one quality adjusted life year, for less than $50,000 was considered, an acceptable, cost-effective intervention. So there was a kind of threshold there. Whereas if my intervention was $150,000 for 1 year of healthy life gained, that would not be considered cost-effective. Now, in low and middle income countries, there aren't these explicit thresholds, but you can use other devices. So, for example, in the WHO's WHO Choice program on cost effectiveness used the average per capita income of a country to say whether something was, like a threshold for saying whether something was very cost effective or not. Or it could just be somewhat rather sort of arbitrary value. So if you're, like it says here, each case averted costs less than $100, or each healthy life year gained is less than the average, then that could be considered a cost-effective use of resources. So it's rather a context-specific issue, and so we need to know something about the sort of willingness of decision makers in your local context to what is the value that they would place on one unit of health that you gain as a result of your innovation. Now, how can I find out more? There are certainly from myself, and we can post some of these up on the Mental Health Innovation Network website. There are available service use questionnaires, costing templates, some brief guidelines on, for example, how to do economical analysis alongside community-based mental health care evaluation. One or two sort of like PowerPoint presentations like this one, which can help sort of get you going. There's also, I recently discovered a self-study online course provided by the National Institutes of Health in the US, which is an excellent resource for people who want to have time to go a bit more into some of the concepts, the principles, and the practice of doing economic analysis. So a couple of resources there. Okay, so I think that takes us through most of the frequently asked questions that we sort of posed. Here is just an example of a completed economic evaluation. This was for a task-shifting intervention for common mental disorders in Goa, in India. You see the publication in the WHO Bulletin from 2012. So, for example, this was the design here was a cost-effectiveness analysis conducted alongside a randomized clinical trial called the MANET study, and the economic question that was being addressed, the hypothesis, was that the collaborative stepped care model being assessed in this intervention as being led by lay health workers would promote a recovery or restore functioning in a more cost-effective manner than conventional care. So that was the economic question that we set out to answer. Information was collected about depression status and the severity of depression of the participants of the study, as well as disability scores collected through this WHO WHO-DAS instrument. We were also able to estimate the quality adjusted life years that were achieved in each of the groups and make a comparison between them. In terms of the cost measures, we looked both at the actual cost of the intervention itself, as well as any associated, healthcare visits to hospitals or primary care, medication use and lab tests. Those were the main health system costs. Time costs, we collected information about the time spent traveling to health centres and health-seeking costs, as well as any lost productive time as a result of their ill health, and how much that was changed as a result of intervention over time. What we found is that the health system costs did not really change. So even though we had a new way of doing things, so there was some costs involved in training the lay health workers, for example, but this didn't have any noticeable impact on the actual overall cost to the health system. And we also found that the time costs were appreciably reduced in the intervention arm. Symptoms also improved in that intervention arm. Therefore, we were able to conclude that the hypothesis that collaborative step care by lay health workers would be a more cost-effective approach to conventional care. We were able to make that conclusion and affirm that. So here's an example, very quick overview of an example of a recently completed economic evaluation in the area of global mental health. Now, we've got one or two questions from members of the network who submitted questions for discussion. Here they are. So the first one here is the following. What is the role that mental health economics should play in pushing mental health in the development agenda? Okay, so that's a great question and a somewhat broader one. I guess I've been mainly talking about economic analysis alongside clinical trials, or let's call it global mental health innovation studies, which are kind of very context-specific studies in those cases. So this is asking a broader one about how can mental health economics really contribute to a broader agenda at a national and global level. So I'd say really three things here. One is obviously to summarize build the evidence base, the economic evidence base, so generating more cost-effectiveness information and then summarize and synthesize that. For the reasons I was saying at the beginning, the why question, it's an important part of the case that can be made and brought forward. Also, building on the cost effectiveness, you can make statements about, well, what is the return on investment? So that's another important area which I'll speak to actually from the second question as well. And the third area, which I haven't really touched on today, but this is to do with more the financing side. So we've been talking mainly about economic analysis alongside clinical trials. So economic evaluation, basically trying to say, is the innovation or intervention a good use of resources, yes or no? So let's say the answer is yes. So then we move to another question. Well, how is that actually going to be, that intervention going to be scaled up and made available? What's it going to cost, and is it affordable over time? And that brings into questions of the sustainability of the intervention. Are there appropriate financing sources or financing mechanisms for ensuring access to those cost-effective interventions? So I think another role would be in that area, but contribution to discussions and debates around how, for example, to ensure that people with mental disorders are covered by essential healthcare packages or covered by insurance schemes in countries, particularly the poor. Often in lower income countries, people with mental disorders are excluded, from these essential care packages. And one of the tasks, I think, is to work to ensure that those people are included in insurance or financial protection schemes. And this can be, I think, addressed and promoted as part of the push to move towards universal healthcare. So let's go to question 2 here. The question was, how can mental health economics help make the case for better mental health intervention, services and policies? So I think here it's rather a similar kind of question to the one above. But I think specifically here, I think the key word for me here would be making the case. So I think what we have to date is increasing evidence on the effectiveness of interventions and innovations. So we're also increasing the availability of evidence on cost effectiveness. But where we've so far been so weak, I think, is demonstrating the broader benefits of investment. So I was talking a bit earlier about the health outcomes of an intervention, but also the social and economic outcomes. And I think those need to be more strongly captured and highlighted and assessed, because that would enable a stronger argument to be presented that says not only is intervention or scaling up mental health services more generally good from a public health point of view, but also from a more broad social or societal or macroeconomic point of view. So, for example, they able to demonstrate that for every $1 that you invest, you get $3 or $10 or $5 back in terms of economic benefits, ability of people to go back to work and therefore be productive, more productive. So I think that is a key requirement, to make a stronger case for better mental health. Okay, so then let's move finally to this question, actually 3 here. It says 2, but 3. What are the problems with the current methods used to calculate values and qualities, especially regarding the social preferences built in their calculation? So that would be things like social preferences is referring to things like discounting and age weighting. Are values and qualities valid summary measures of population health? Okay, let me answer the second part first, and maybe inevitably because values are kind of associated with much of the work that I've done over a number of years. I'm going to say yes. I think they are appropriate and valid summary measures of population health, but they are not without their limitations, and so I think that's the first part of the question. I think really the main contention is, as I've put here, the D of values, or the Q of qualities, which is, these are composite measures of the quantity of life and the quality of life, or the disability associated with a health state that you measure over time. So this is really the crux of the kind of the measurement issue, and there have been many long-standing debates about the quality of the data that's been used to derive these measures, or, for example, disability, going back right to the first global burden of disease study that was published back in the late 1990s. And those are still going on now, even though the science around the measurement of disability has improved and developed over that period. So even now, the latest global burden of disease estimates, using large population-based surveys in a number of developing countries, it still at times gives what could only be described as counterintuitive results. So that means that there's always questions being asked about how correct and how accurate are the disability rates, for example, used in the calculation of disability-adjusted life years. And so I think it's an ongoing process of improvement and revision, and I think that is ongoing, really. I think that's what I can say to that question. I'm seeing that we're pretty much out of time here. We're up at about 45 minutes. So I think at this point I'm going to bring things to a close, and thank everyone for attending this session. And we will, of course, be putting the recording of this session up on the website if you want to come back to it or share it with other colleagues. But for now, thanks very much, and goodbye.